So wait.
If you decide where you're concentrating, it's really, you've been enough concerned that you put it you really should have to see the operation. I don't know if you know that.
Your can is everywhere.
Because then what you're doing, you have already transected.
No, it was. We were like, the specimen was like just hanging out.
Right, transected, and that's responsible. That's what we do. Yeah.
I was double scrubbed for like, everyone was close to coming out. By the way, good. Okay, not today.
We can't hear you. There's like a button on it. We're getting there. Eric and I discovered that time we could.
It's your O6 voice.
That sounds like.
I dug it up. Driving up. I ordered Lyden's coming to Spain. So.
How are you? Good.
Where did you get that skill set? I'm having.
I'll get that letter. I'll send you a copy of the letter I wrote. Review it. That one we can hear. Like give them a bath or whatever.
Nobody can hear me. All right, let's go ahead and take our seats. Good morning, everybody, and welcome to the 2025 J. Cherry Lectureship. I'm really honored and happy to have Dr. Cherry with us. Most of you know Dr. Cherry. Fortunately, he went for his undergraduate degree at Duke. Sorry about that. But then he made it to UVA as soon as he could, and he went to medical school at UVA and did his surgical residency here at UVA. Then went out to UCSF and trained under Jack Wiley, San Francisco. That was in 1980 and 81. Then he went directly to the Mayo Clinic and had a long and illustrious career as a very complex open vascular surgeon. In 2004, he came to UVA, became chief of the division until 2010. Finished his career as a surgical consultant in Norfolk. We all know Dr. Cherry very well. We want to thank him, and we're proud to have this lectureship that honors him and his career. I'd like to introduce our 2025 Cherry Lecturer. It's Dr. Sean Lyden, who's the chair of vascular surgery at the Cleveland Clinic. He's truly an internationally known and respected leader in vascular surgery. He's from Youngstown, Ohio, and he, like Julie, his daughters, all went to Notre Dame. True Golden Gomers. I'm sorry. He attended medical school at the University of Cincinnati and did surgical residency in Memphis. And then he went north, getting his fellowship in vascular surgery at the University of Rochester. He left Rochester in 2000, finished in 2001, and went to Cleveland Clinic and has never left. He's developed a very complex practice in open surgery, endovascular interventions. He, in 2016, became chairman of vascular surgery at Cleveland Clinic. He's been president of the Midwestern Vascular Society. He's currently president of the physicians. I'm really honored to have Sean, who's a good friend, here for the 2025 Cherry Lectureship. I'm honored to be here, and I'll say that I may not look it, but I am the oldest person you'll ever have lecture, and that's witnessed by the fact that Dr. Cherry was actually my fellow before he came back to UVA in 2004. When he left Mayo, he made a little stop in Cleveland Clinic to learn how to do a little bit of endovascular. And I can say I'm indebted for him because besides having to teach him how to manage a catheter or wire here and there, we also dragged him into all our open rooms and learned a little bit from him about his open technique. And the first aneurysm I was doing when he was there, I brought him to the room and I said, "Hey, show me some techniques." And the first thing he said, "Your clamps are all wrong, John. They're all wrong." And I'm like, "Okay, Dr. Cherry, what do we need to order? You'll help me." Here are my disclosures. Hopefully none of them are actually relevant. data. So stroke, it causes about 700,000 strokes a year, and it's actually the #1 cause of disability in the United States. However, all strokes are not due to carotid disease, only 15 or 20%. But it is very expensive to healthcare, and if you realize what our government cares about, they care about cost. And the cost is about almost $60 billion a year, and where the cost really comes in is those people who survive stroke. 20% will require institutional care, and about a third will have permanent disability. And patients fear this a lot. They don't really fear aneurysm so much, but as disabling for stroke is really terrifying to patients. So we know very well the risk factor for stroke is hypertension, carotid disease, diabetes, smoking, tobacco use, atrial fibrillation, heart disease, and high cholesterol. So who's at risk? If you have an asymptomatic carotid stenosis, depending on which study you want to quote, you have an annual risk of a stroke of anywhere between 1 and 4.3%. And you can see by stenosis severity, people have strokes by non-atherosclerotic means, which is why you can have no carotid stenosis, still have a stroke, but it goes up quite a bit once you get above 80%. If you've had a TIA, it's really a bad prognosticator. You're going to have 50% risk of stroke in the next month, 30% within the next 3 months. So I always learn surgical history, and that's always something to talk about. So the first is apoplexy of the carotid was 400 BC. Not much really went on until you get to the 18th century, where Astley and Cooper ligated a carotid aneurysm. And then for my first institution had a little influence is Dr. Charles Robb had come to the University of Rochester from England, but he was actually one of the first people to actually successfully describe a carotid reconstruction. So we talk about that. There's always a debate, and if you want to debate who did it first, there's always going to be the debate of who was Dr. DeBakey or not. But actually, if you look, Dr. DeBakey did describe on August 7, 1953, partial transection of carotid bifurcation, removal of plaque and fresh clot, where the patient actually did not survive. So if you talk about that, you can see this is actually from that paper, and we'll talk about different techniques. This looks like similar to some UVA version carotid endarterectomy. A challenge, that angiogram doesn't seem to be the world's greatest endpoint. Maybe that's why the patient didn't recover and do so well, and very different from the neuro techniques I know from some of the neurointervention colleagues in the room have here today. So really, this first successful carotid surgery was reported by Dr. Pickering and Robb, and that was a person who had intermittent taxa hemiplegia, and they actually reconstructed the carotid with an interposition. That patient had did well. So, take that forward now to the 1990s. Now, I am a medical student. I was training in Cincinnati, where Tom Brott and some other people were just really leading stroke care in Cincinnati. And there were 2 very big trials going on during my time. And that first one was the NASA trial, which looked at symptomatic carotids. And that really showed for symptomatic disease greater than 70%, we should fix them with a 5.8% episode of stroke and death at 30 days, being what kind of surgery, but the cumulative stroke risk in 2 years was 26% for medical management versus 9% for surgical management. They subsequently then looked at lesser degrees of stenosis, and we'll talk about that in a minute. That was followed by the ACAS study. That showed that you had a 2.8% risk of stroke and death at 30 days when you were fixed. 1% of those were from diagnostic angiography, which is a little different than it is now. We didn't have the catheters we did. A lot of times they was from pistol whip. We needed power injections in the arch, and people were not as facile of getting in through the arch as we are now. But that study was stopped early because of the risk, and they estimated aggregated risk over 5 years of 11% of stroke for medical management versus 5% for surgical management. That really put out the guideline that still sits today for asymptomatic carotids, that you should be doing with less than 3% periop in morbidity and mortality, aggressive risk factor management of their medical factors. Then studied it further. Like I said, the NASA study had a secondary study that looked at the lesser degrees of stenosis. You can see greater than 50% stenosis. There's still a benefit that's where it's only about a 6% benefit. That was followed up by the VA cooperative trial that once again showed similar degrees of efficacy for greater than 50% stenosis. And then, as we noted before, the ACAS trial. But what was medical management in the late 80s and 90s? Well, you had aspirin and dipyridamole. You had hypertension control with a lot of central acting agents that were just really starting people to use beta blockade, but not predominance beta blockade. We're telling people to stop smoking, and diabetes control with basic metformin and insulin, but that was really it. So we now have a lot better medical management. People would say that, hey, maybe you don't need to fix your with better medical management. ACEs and ARBs, and we know those decrease incidence of stroke. We have beta blockade, which lowers your cardiovascular risk. We now have statins, and I'm sure half the people in the room that are my age are on one like I am. And you also have now PCSK9 inhibitors, which are more effective at lipid control over infection. There was just a study that came out last week showing combination therapy actually being maybe the best. And now we have better antiplatelet medicines, and we've all been, as surgeons, been subject to working on people that are on some of these very effective antiplatelet medications that you're spending a lot of time with hemostasis control and operations that aren't so. We're also better at diabetes management. First thought the lower you drive to hemoglobin A1C, the better. And we found that that may not be the best. In the core and advanced trials, we found that increased tight glucose control actually led to higher mortality. So now since then we have GLP-1 agonists, SGLT2 inhibitors, which besides having better glucose control for the patients that are not type 1 diabetics, get some weight loss, and it also lowers your cardiovascular risk. So surgery had always been a longitudinal arterotomy, and then an endarterectomy, and then there's a whole lot of controversy of endpoint management, and at the clinic, Dr. Hercher, who's one of my predecessors, has written a lot about. We'll talk about some of what he said at the end, and then also if you're going to attack proximally or distally. And originally it was mostly primary closure, but has evolved to patch closure, and then eversion. We'll talk about that in a minute. So this is a picture I got from Dr. Hercher many, many years ago. I've seen it in a lot of people's talks. This was actually I got from his original slide set. See him using the Struley scissors to transect the distal carotid. And then after he was done, you can always know it was a Dr. Hercher picture because he tacked every distal endpoint he ever did. And they were all with 5-0 silks that were soaked in mineral. Yes, Dr. Cherry is having visceral reaction pain when he sees that. And then later, he also started attacking the proximal endpoint. So the other way to do it is eversion. And I'd never seen this until I was a fellow. I was at University of Rochester, and Dick Green transected the internal carotid and amputated, and I'm like, and then he put it back together, and I was like, oh, I better go home and read about this. And I was like, we didn't want to tell him I didn't know what I was doing, but there's two ways of doing it. The group in Hopkins sort of transects the common right at the bulb and sort of everts both. I've always found that really impossible to do it. I sort of do it the way the Albany group does, which is you're basically amputating off the internal, extending the arteriotomy up the internal and down the common. And what are the advantages of an eversion? You don't do it every time, but it's clearly faster. You don't need a patch or synthetic material. When you have a redundant or looped internal carotid, it makes it easy to deal with that. It has a similar restenosis rate to patching. But you do have to more extensive dissection of the bulb. Unlike the Albany group, find it impossible to shunt with an eversion. They talk about how easy it is. I'd someday want to be visiting professor and watch how they do that, because I've not figured out how to do that in my 30 years as a vascular surgeon. And if there's long and high lesions, I think it's a little more difficult than I do standard endarterectomy and patch. But we know patching works better than primary closure. And one of the trials that showed that to us was the Everest trial, which was really set up to look at patching versus primary closure. And you look at the restenosis rate and the event rate, that you had higher acute occlusion and restenosis rate when you had primary closure. But in that trial, there were a significant number of patients who had an eversion endarterectomy. The eversions actually had a identical outcome to the patch. So no matter whether you're an everter or a patcher, they generally works better than primary closure. However, I would say if you're a very good carotid surgeon, you have a big carotid artery, you can still do primary closure very well. And I know one of my dear friends, Mike Macron, still primary closes about 70% of his with a less than 1% stroke rate. So the next thing was, how do you close the patch? Is it a vein patch? Is it a dacron patch? Is it PTFE for Aliabarama or bovine pericardium? I'd say across the United States now it's mostly bovine pericardium. Dr. Hercher had some different views, and we'll talk about those. There's been a lot of influence on carotid disease from the Cleveland Clinic. Dr. Hercher always used vein patching, and it always had to be vein patching for the groin, because he felt that when you use ankle saphenous vein, it was weaker and had a higher degree of blowout. So Pat O'Hara, who was one of my partners, actually during his time there, he actually did a randomized study of saphenous vein patching versus synthetic patching and really found no difference in this randomized cohort. And that really helped all the rest of the partners not using vein patching. However, Dr. Hercher, the consummate studier, and his SBS address was results mean everything. And he spent his entire career and even his emeritus career sort of looking at his results. And so this was his own experience of carotid surgery. And you can see whether he was first at primary closure versus synthetic patching versus vein patching, his perioperative stroke rate and carotid thrombosis rate. And he remained adamant for his entire lifetime that vein was superior. He'd also spent a lot of time looking back at his own results over time. He first didn't tack his distal endpoints. He then tacked all his distal endpoints, and later on, he had a patient that anecdotally had a postoperative thrombosis. When he took the patient back to surgery, he found a big lip at the proximal endpoint. And so after then, he actually tacked both all his distal and proximal endpoints. And I still have 2 partners who use Silk tacks to this day, whereas I think pretty much every other vascular surgeon in the world uses Proline. He also looked at carotid endarterectomy versus CABG. We have some cardiac surgeons in the room. My philosophy now is, who's my cardiac surgeon? How long are they be on pump? Are they doing the valve or not? To try and figure out, is this going to be staged? Is this going to be simultaneous? And what's going to go first? But when he looked at the Cleveland Clinic data, you can see that the combined risk of stroke and death for carotiectomy alone was 2.4%. If you did the CABG first, it was 4.3%. If you did the carotid first, it was 6.6%. If you did it together, simultaneous, 8.9%. And so it's really not about what needs treated first. If they're both symptomatic, you're sort of stuck. However, if there's one that's not symptomatic, you can sometimes wait. But sometimes it's how fast your vascular surgeon is, or your neurosurgeon, whoever's doing the surgery. And the other thing is how quick your heart surgeon is. What are they doing in the arch? And what's the disease actually from stroke from the arch? Because some of them clearly don't come from that. We've also studied how you neuromonitor. And this is sort of, you can have your religions, and there's lots of religions. So I never did surgical block until I became a fellow. And when I was a fellow, I remember a patient one day wanting to get up to have a number 2 in the middle of the case. And I swore I'd never do a surgical block ever. And then in practice, because you get to know how your patients are doing, you don't have to wait for that time of them waking up. As a trainee, you don't get this, but when you become a vascular surgeon, the most stressful time your whole first year of your career is that general anesthesia carotid, waiting for them to wake up to make sure they're not hemiplegic and doing okay. So I've now gone to doing some cervical blocks. Some people clamp and sew. Some people are obligate shunters. I trained in Memphis, and they were influenced by Ed Garrett Jr., and they obligate shunted everybody. I've then evolved to stump pressures, and that's really because I hate shunting and I hate working around a shunt, and I've now learned everything I can do to minimize using a shunt. In my fellowship, we did EEG, and we actually did EEG both on awake and asleep patients, and found patients who had neuro changes by EEG when they're normal awake. And so it wasn't really the greatest predictor, but if you want to shunt 20% of people, EEG is a great way to do it. Cerebral oximetry has been popular in the last couple of years. It's about essentially both credentials and TCD. And TCD is probably a really good way to see both middle screw flow and embolic events and hits, but it's really cumbersome to set up, and a lot of people do not have an installation window. You can see that. And then, once again, the religion and carotid disease continues. If you're a shunter, what shunt do you want to use? I tend to like the internal carotid sun shunt. All my partners that trained under Dr. Berger use the external carotid shunt. One's this long, one's this long. I have partners who use a jab and argyle shunt, and I've even had one partner who was a fan of the Pruitt Inahara shunt. And so, if you're going to shunt, what shunt do you want to use? And I would just challenge, be facile at one. Realizing that sometimes not one size fits all, because if you have a really small internal carotid, sometimes that sun shunt, the smallest sun shunt, won't fit into the internal, and then you're going to have to pull out one of the argyles because they tend to have smaller sizes. Well, religion continues in carotid disease. After you're done, how do you actually figure out how the repair did? Most people do Doppler insufflation. During my fellowship, we started doing completion duplexes. I still do those to this day. Vic Cashup was one of my partners, was trained by Wes Moore, and he does cerebral angiography on every patient. Alan Lumpson does TCD on those patients, and some people do cerebral oximetry. It doesn't matter as long as you look at your outcomes, if you're good how you do it. All these ways can be helpful. I sort of like the fact that if I make sure my endpoint looks good, both visually before I close and after restored flow, I found that very helpful and reassuring to me. So what do these outcomes look like? And we look at, hey, where we sat for the 2000s. Dr. Hertzer wrote up the Cleveland experience of almost 2,300 patients with a stroke risk of 0.5%, a mortality of 1.8%. And once again, he continued to reaffirm his bias. The stroke risk was higher with synthetic passion than primary closure versus vein. And generally, at this time, it was Dacron. It was pretty thick. It wasn't as easy to deal with. And so maybe that was just by complexity mismatch or other issues, but it also written about people that were older, and now an octogenarian doesn't seem so old, because we tend to have people now in their 90s. And so this is 182 patients, stroke risk of just a little bit higher, 1.6%, a TI risk of 1.1%, a 5-year freedom from stroke of 85%. And we also spent some time looking at a reoperations. This was for 200 reoperations. Once again, the risk goes up just a little bit as the surgery gets a little more complex with a stroke risk of 2.9% and a death rate of 1%. These were both symptomatic and asymptomatic patients. So this is a review of what was going on in the world. And between 1980 and 1996, almost 15,000 operations. Interestingly, if you look at then compared to now, you can see the vast majority were symptomatic. Where if you look at today's world, about 85% of people being done are asymptomatic. And you can see for symptomatic patients, a stroke mortality rate of 5.2%, and for asymptomatic, 3.4%. And those are the American Stroke and American Heart Association guidelines that remain to this day. So carotids, what do we know about all this? You can do calcium and tortuosity, you can do general, local, regional. If you have good hands and you look at your own data, you can do it well. It's really excellent at stroke prevention. However, it does have a risk of MI, and it does have about a 4% risk of cranial nerve injury. But then they're transient, get better, unless you're the patient who has it, and then it can be really not so fun. So where were we at the end of the 90s? We were doing about 15,000 carotid operations per year. This wasn't a very difficult surgery to help patients. They recover really quick. You're in the hospital 1 or 2 days, usually about 2 days. You knew really well the risk of stroke and death for symptomatic and asymptomatic patients. It was less than 2.5% for asymptomatic patients. However, it was about that time that angioplasty and stenting came along, and there really became this whole discussion of, will this incision disappear? And I would tell you, this is where the surgical community and the intervention community not like each other. We were not really friendly to each other. But Ken Oriole was that left Rochester, and just before I got to do my fellowship at Godley Clinic, and he was a consummate studier of data. And Ken could get on a plane from LA and land in Cleveland and have an entire paper written. And he looked at the Cleveland Clinic data for high-risk patients, and those patients he defined as needing a coronary angioplasty or open heart with 6 months preceding their carotid, the history of heart failure, severe COPD, or patients renal insufficient creatinine greater than 3. And you can look, those patients, 3,000 patients he looked at done at the Cleveland Clinic, Dr. Herter's registry, that there clearly probably was a high-risk group that did not look like the 2,000 patients that Dr. Herter reported on. So when was the first carotid angioplasty? Dr. Herter reported on it in neuroradiology in the 1980s. The early series was changed by Ted Dietrich, who was a cardiac surgeon out of Arizona Heart. And his first series had a 10% episodic stroke rate. And really it started to change when Jay Yadav, who was first a neurologist and then became an interventional cardiologist, who actually developed the first carotid protection device, the AngioGuard, and a carotid stent. So over time, people started saying, well, hey, if we do it, we need to protect the brain. And so people put up distal filters and distal occlusion balloons. They had a device that created a balloon proximally in the external to stop flow into the endocarotid. Juan Perotti invented a device that actually had a distal external carotid filter, a proximal common carotid filter, and then a connection to the femoral vein to create full flow reversal, which eventually became the concept for TCAR, as well as just having occlusion balloons. And now it's amazing, in the neurointerventional world, the proximal occlusion balloons are really helping reinvigorate how they treat stroke, because they can actually now get in much farther and do things to the brain. What wasn't hard to figure out when you see your first filter to a carotid stent, why you need a filter. Because if you see this after doing an angioplasty stent, as a vascular surgeon, as a trainee, there's this visceral reaction like, oh my gosh. And when you do an endorectomy, sometimes it's this calcified hard rock, and sometimes it's just liquid toothpaste. And how a carotid stent ever worked, I would say every vascular surgeon in the room sort of had angina when we started putting stents and vessels anywhere, let alone the carotid. So how do carotid stents work? Well, when I first started doing it as a fellow in the 90s, you do an arch evaluation, you do a selective carotid catheterization. You would actually, over a stiff wire, either landing short in the common carotid or the external, bring your sheath in. Once you brought your sheath in, you'd cross and pull your filter. You're going to pre-dilate the lesion, place your stent, post-dilate, and then you got to get your filter on. And I would say that when I first started getting the clinic, I was required by Jay Otta and Dan Clare to do 100 carotid stents with another faculty member before I was allowed to do them independently. And back at the time, from 2001 to 2005, carotid stents were really going crazy. Industry was loving it. Every one I did was with a different device, a different company, and a different trial. And let me tell you, it was maddening trying to sort of get good at it when, okay, I was using this device, this one, the next case I was doing that one, you might do 2 or 3 in a day. And it's hard to get good at things when everything you do is different techniques. It's really hard to do sessions. So this is a patient of mine way back from 2004, before and after. And that actually looks really good. So what did we learn in the 2005 by carotid setting? Clearly had a lower MI rate. We'll talk about that study. Percutaneous. We were doing 500 carotids a year at the Cleveland Clinic. Once carotid stent trials came along, soon we were doing 400 carotid stents a year. Because guess what? Patients see an operation like this or puncture like this. It didn't get really hard for patients to sit there and drive saying, hey, if it might be better, I want this done. It's no different than someone who has coronary artery disease, how they've always picked coronary angioplasty stent, even though for a long time the results were inferior as opposed to having your sternum split. We've really now shown that it really has an equivalent risk of major stroke and death in carotid for a long time ago. And it has an equivalent risk of restenosis. We all thought that the restenosis rate was going to be much higher. And I sat there and waited anxiously to have that data come so I could prove that maybe it wasn't the best option. And we now have a better idea of what anatomies to treat. We'll talk about that. We know that you can do both proximal and distal embolic protection. But there's still some issues with it. If you have a densely calcified lesion, it doesn't work well. It's hard to get through some difficult arches, and you can cause issues when you're working through the arch. When you do the post-dilatation of the stent, you can get plaque protrusion through the stent, and that's really the time of highest risk. We know that when you do carotid interventions, that there are silent brain regions. There is some data showing that that may lead to late cognitive decline. And then there is always been a much higher increase of minor stroke rate. And that's really what the vascular surgery colleagues, including myself, has set on saying surgery is better. Well, this was the first paper that came out. You can see Jay Yodoff was the lead author, but Ken Oreo was one of the other authors that came out in the New England Journal. And what they did was unique. They took stroke, death, and added MI. Before then, everything we'd ever talk about was just stroke risk and death risk. And once you added stroke, death, and MI, carotid stenting, this was a non-inferior trial, but became superior with the addition of MI. And there was a whole lot of debate. What did that mean for the patients? Well, the cardiologist would sit there and say, well, guess what? There's some studies that show there's 6 times higher risk of mortality within the first 12 months after suffering a non-QM MI. That wasn't necessarily in patients who had a carotid intervention. And those patients are 20 more times likely to have subsequent MI in the 6 months post-procedure. So there's always been a debate what that meant in prognostication for the patient. And we do know that it does have some late risk for the patient. So, take this forward to 2004, carotid stenting is improved. And when it first got approved, there was high risk criteria. You'd had a previous surgery, radiation, a high lesion, a low lesion, and I can tell you that's been highly debated of what that is. FMD, neurologic instability, precardiac surgery, and it was approved for 50% symptomatic stenosis, asymptomatic 80% stenosis. And you had to have heart failure, open heart within the next 6 weeks, unstable angina, severe cardiac disease, requiring surgery or pulmonary. So it was long awaited, but all us vascular surgeons were terrified this was going to abuse. And so we went to the government and said, this is going to be a problem. And then CMS basically said, hey, we're going to put some limitations on it. We're going to say only approved trials, only for approved devices. And really what this did is this really put a huge limitation on how it can be done. So if you look at the CMS guidelines, after 2005, it said you can only do stenting for now just symptomatic, greater than 70%, and high risk with approved devices for patients in clinical research trials. And you also had to be approved as a site for carotid stenting. You had to track your outcomes, and you had to submit them. And in that, at the Cleveland Clinic, we started a joint conference that we still have to this day with our neuroradiologists, our neurologists, and our neurosurgeons that we keep track of our data. It was one good things I think that came out of this decision. Well, what didn't they do? Well, they said, well, credentialing need to be at the local level because CMS said they can't regulate that. And then you had all the different societies. It was American College of Cardiology, American College of Physicians, SCI, Society of Vascular Medicine, SVS, all came out with different standards. If you were going to do this, how to do it. It may have been, 25 procedures above the arch. Some diagnostic, some interventional, and you can do it. Or, the neurointervention radiologist said, hey, you got to do 100. And so there was a lot of debate of how you can do this, how you get good at it. And you can see that it was all over the place. And this was a lot of debate of who should be doing it, how they should be doing it, and how they get access to it. So time goes on, and industry was not know about this because it's a lot of patients. And then they went back to CMS and said, hey, maybe we can pursue some changes that we can start doing asymptomatic patients 80% because we know from the FDA there's devices safe and effective to treat those patients. They offered mandating surgeon that was carotid credentialed to evaluate the patient and no coverage if you were in octogenarian, no coverage if protection wasn't used. And once again, it got open for public comment. There was a lot of physician and industry input. There was a lot of societal input. And really, almost all the proposed changes were rejected, except you now have to use emboli protection or it's not going to be covered. So now it has to be high-risk patients. It still has to be symptomatic greater than 70%. And they sort of evolved what was high risk. And so if you look at what happened after this, at the Cleveland Clinic, where the trials started drying up, we're doing 400 carotid stents a year, now industry is sort of losing interest. And so it really becomes maybe 5% of the patients we see have Medicare, meet one of these high risk criteria. And our institution was very serious about there's no fudging of this. They either have it or they don't. And what was really the big discussion point is that minor stroke has always been higher with stent. And so that's been seen across trials and across decades. Why does that happen when you use embolic protection? Well, all the different devices have different openings or pore sizes. If you improperly size it, it may not oppose the wall, and you can have other issues. So that's when really the combination of say, hey, getting in the arch causes strokes. How do we achieve that? So some surgeons got with them and said, hey, we're going to make a little incision neck. We're going to put an IV in the neck. And then we're going to do flow reversal, the exact same methodology that the carotid protection device did, and then clamp the common carotid, create flow reversal, and have it dump into the vein. That led to approval of that technology in 2015. And it's been studied, and one of the unique things of when it got approved, it was required to be studied in a registry. So it had to be studied in the Vascular Quality Initiative. And the SVS has benefited from this because of the 1,000 sites that have the VQI, probably 98% have the TCAR module because that was the only way you could access the TCAR. So you had to collect the data. It had to be in a registry. If you look in hospitals, stroke and death rates look pretty much just like carotid endarterectomy, even though they've never been studied head to head. The procedures were a little bit faster, and because you're not dissecting up in the bulb, your risk of cranial nerve injury was lower, but isn't zero. So what are the advantages of TCAR? Well, had the VQI and had that module, it was covered. It avoided the arch. I would clearly say it's easier access for less skilled endovascular MDs. So you didn't have to get a sheath from the groin or from the arm into the arch, and that is difficult sometimes. And if you have a tortuous internal carotid, you didn't have to cross that tortuosity with a filter. The learning curve was a lot shorter. Not maybe the 70 cases for carotid stenting. It's 5 to 15 cases. You need 5 centimeters undiseased common carotid from the clavicle to where you're going to actually put your stent. It still requires incision. You're trying to put the clamp in that small hole. You can still clamp Vegas and get nerve injuries. And the other issue, which really held up access at my institution, was it's expensive. Carotid surgery was paying about 22 grand to your hospital. The stenting was paying 26, 27. And guess what? The Silk Road device cost your hospital about 7 grand. So it actually, they originally started marketing it because you can make more money for your hospital, but it didn't actually make more money for your hospital because you spend it all on the device. So now take us forward to November of 2023. Now, in my practice, less than 10% of my patients and the neurointervention patients actually qualify. And if you're private pay, well, maybe some mirrored Medicare, some mirrored FDA labeling, some would just say carotid stenting is experimental. And there's nothing worse as a patient than that you sit there and decide you want to have something done, your doctor decides something done, and now you're not going to get paid for it, and you do it, and then the patient gets stuck with a big bill. Or if you do it and you get audited for the Medicare patient, hey, it's fraud, you can go to jail. That's kind of a big deal to me and my wife. And the other thing is, if the patient has a complication, that entire hospitalization is on the patient. So that's really stifled innovation. But along the way, I would say we actually learned a lot. We kept studying carotid stenting. And so I, with some other physicians, wrote a review in Jack to look at the current data from the last time CMS had been asked to review it in 27. You can see with all the studies were done, there clearly was a learning curve, and we got better with outcomes, although it never got to meet surgical outcomes. And we knew the big issue is when do those occur? It's not getting in, and usually post-dilatation period is when most of the strokes occur. And there's always a late risk that you have protrusion of the plaque through the stent. It's really when you do that post-dilatation, there's nothing worse when you're a awake patient. Take that balloon down, and now they're not doing so well. And I'm calling my neurointerventional radiology colleagues and say, hey, what you doing? I know what you're doing in 4 minutes. Come on up to my lab and help me out. So there's been a lot of scrutiny, and there are actually a bunch of randomized trials. There are 4 large randomized trials. We'll talk about those in a minute. That looked at almost 7,000 patients. It really showed in the conclusions of the study, equivalence between carotid endarterectomy and both the procedural outcomes, long-term outcomes, and durability. So the first was the CREST trial, which looked at symptomatic greater than 50%, 70% asymptomatic. And you look at the primary endpoint of stroke, death, and MI. And you can sit there and say stroke, death, and MI for whatever it is. At least for surgery versus endarterectomy, it was 5.2 versus 4.5. And that had about over 1,000 patients in each symptomatic and asymptomatic. So what was new after CREST? And this is a little hard to read, so I blew it up. But if you look at Act 1, which was industry-sponsored trial, randomized people 3-to-1 surgery versus stenting with the Abbott device, and you can see both carotid stenting versus carotid endarterectomy, which was a list of high and low-risk patients, but no difference. Phase 2 trial through 1 year with equivalent outcomes, ACST trial now with 5-year follow-up showing no difference. And everything we learned along the way is we shouldn't be doing this in everybody, and we started talking about how you classify an arch, whether it was simple, medium, or complex, a type 1, a type 2, or type 3 arch. And I can tell you, I've done a lot of type 3 arches. Now, because we have TCAR and other options, most people won't, and you avoid it. And we never got CT scans ahead of time. We get CT scans all the time. And so I had to go back and look for some old cases where, I was doing a left carotid. You can see how far down that type 3 arch comes. And once you get your sheath in and it starts kicking a little bit, now trying to push your balloons in, your stents in, your sheath wants to be backing out. And I can tell you, I've done some things that I probably would never want to say in this room of getting the stents in and completed, but it did lead to a higher risk. If you're going to treat people, then what protection are you doing? If the external's out, you can't use devices that an occlusion balloon in the external. What did the lesion look like? How calcified was? If there's stitchal tortuosity, there's a room to put a filter proximal to it. Because once you go through that, it translates all that up. And once it does, you may not have good apposition of your filters. So these are all lesions that I have or friends have had that have treated with carotid stents. So I'd also are probably 4 candidates where you have really string signs of really calcified lesions or eccentric lesions and trying to make double U-turn bends to get across. Resolve all this discussion about what kind of stent to use, open cell or closed cell. Closed cell have very small scaffold, but they're very inflexible. So you put a straight carotid, a closed cell stent is great. But an open cell conforms really well, but it tends to fish scale. So when you're trying to get your protection device out or other things in, it can catch. And so there's been a lot of debate, and the early data showed closed cell are better, and now most of the devices are sort of a combination of closed and open cell. So there's some debate that maybe that actually doesn't hold water. So if you look at closed cell versus open cell, a open cell has more area that plaque can come through, but if you look at the chunk of plaque that come through, they're about the same between all the stents. Once you start adding some tortuosity in, these openings become much bigger. So the most recent innovation is add other layers within it. And you can see an open cell stent, the area that is open versus a closed cell stent versus 3 carotid stents, the Gore carotid stent. They never gave it a brand name, never put it for sale. The Truma Road Saver, which actually got approved about 3-4 months ago, and the Inspire ND, which is completed trials we'll talk about. You can see that the open pore size to prevent that plaque protrusion is continued to decrease. The con of that is that originally they had a higher risk of thrombosis and restenosis. So if you have more fabric there, what's the downside? This is some of the first data from 2021, looking at the C-Guard device and looking at the intracranial lesions, looking at the Aculine stent, which was the stent that was used for the CREST trial. And you can see the lesion number from the central publication. Look at the red line versus blue line. It's very easy to see that with micropicture, it goes down. And these 2 new devices we'll talk about in a minute. The first was the C-Guardian stent. You can see that for the first time, we actually had a stent in a device that actually made outcomes we've seen for surgery. So if you look at stroke, death, or MI, and the per protocol or intent to treat, less than 1%. If you look at major stroke, there was only 1 in 316 patients. And if you look at death or stroke, which is if you're looking at, and this is a high-risk patient population of less than 1%, intent to treat, or 0.63% per protocol. And you can look at the CZ adjudicated adverse events in that trial. The other new device out there is a NeuroGuard IEP, and that basically takes a filter, a stent, and a balloon, and rolls them all into one. You have to still put a filter above it, but that's a very, very small micron filter. So when you're doing the post-dilatation of the stent, it catches other debris. And that's now been reported both 30-day and 1-year outcomes. And you can see the risk of all stroke and intent to treat It's 1.3% per protocol, 0.98%, also high-risk patients. And you see when they now repeated their 1-year results, you can see that the intent to treat risk of stroke, death, and MI was 2.67%. So exceeding 3% risk of stroke and death that you should have for ACC and AHA guidelines. So in 2000, we sat there and said, you know, it's never going to happen. Hell will freeze over like carotid stent happening. And if you look, hey, we're at 2023, hell has potentially frozen over. And so I was part of a group of neuroradiologists, cardiologists, neurosurgeons, vascular surgeons, field at CMS to look at the decision. I would say that I was not basically loved by my society for this. And with that, the National Coverage Determination Policy was altered, and it basically made carotid endarterectomy, carotid surgery, and TCAR all safe choices. And it took away the facility requirements to report to CMS. That continued the whole idea of local credentialing and governance. One thing is they did add was shared decision making was required and documented. And if you're doing carotid interventions, TCAR, or carotid stenting, you now have to be NIH stroke certified. And I can tell you, my partners were not so happy with me when I made them all do that 7-hour per year stroke scale training. And for the neuroradiologists, neurosurgeons, they've had to do it for forever, and it's a pain in the butt. And so it's not easy. But what shared decision making, and there was a lot of discussion with CMS of how you define this, tools you take out there. You have to put the patient's disease in their clinical context. What is their stroke risk, their death risk, their MI risk, with best medical management, with carotid endarterectomy, with TCAR, be present in your hands or in the hands of someone you could refer them to. You don't necessarily have to do all those modalities, but you better know how to discuss them. You need to talk about the patient's longevity and the patient's choices, and you need to document the medical record. And that's where they elected. And I think we eventually will have tools to develop what those risk calculators are, but they don't exist today. There's some new data since that came out. You look at now the 1-year data for C-Guardians, you can see they still have excellent results of intent to treat death, stroke, and MI between 1 month and 365 days of less than 2%. You can see that there was a minor stroke retinal on 6 months out, and there were 2 major strokes that happened just before a year. One that had antiplatelet therapy stopped for prostate surgery, and the other one had AFib, so it could have been a bone. Performance 2 is reported their 2-year outcomes. Between 1 year and 2, there were no neurologic deaths, no stent thrombosis. Clinically driven TR rate was 0.4%, and the in-stent stenosis rate at 2 years is 4%, which is what we have with surgery. So we can't forget surgery. This is looking at BQI, so it's a typo there. And current day practice, 88,000 carotid endarterectomies with a stroke and death rate of 1.5%. Look in the United States, 87% are done conventional with an endarterectomy, 12% are done eversion, 85% of us are doing prosthetic patching. Despite Dr. Hertzer's push, 21% are doing main patching. 40% of us are doing routine shunting, 8% selective shunting, 30% are using EEG. For completion imaging, 60% of people use Doppler insufflation, 30% of us use duplex, and 5% use angiogram. Look at carotid stenting. In the VQI, the 30-day stroke and death rate is higher at 2.9%. But if you look at who's getting treated, we capture everybody in my institution. And the people getting carotid stents in my institution are about 70% symptomatic patients, whereas our carotid endarterectomy patients are about 70% asymptomatic patients. And so when you look at these studies, if you're not breaking down by symptomatic, asymptomatic, it's hard to really say, is that a bigger risk to the patient or not? If you look at TCAR, it looks very similar to surgery with a stroke and death rate at 30 days of 1.6%. So if you look at over time, you can see TCAR has grown. Transfemoral carotid stenting had been very plateaued for 2021. And we've now just recently heard the Roadster 3 trial, and it had really some landmark results. It looked at the population or intent to treat stroke, death, or MI in 288 patients for asymptomatic 1%, symptomatic at 0%. So what's happening since October of 2023 when the NCD was changed? There's really more physician interest. Industry is getting hammered by like, hey, I did carotid stenting when I was younger. I stopped doing it. How do I do it again? And I really think there's new interest in stents. There's been, we'll talk about just a minor uptick in U.S. sales. Boston Scientific bought Silk Road, and so now you have a very big device company buying Silk Road, and then Medtronic just most recently acquired the rights to market the Contigo NeuroGuard IEP. So I met with the industry, and I gave this talk at the SVS last year of, hey, we're worried if this happens up, carotid stents can go crazy. And if you look at this was from November 2022 to September 2024 with about 11% growth in stenting, both TCAR and transfemoral. If you look at just transcarotid uses, and I got data from all the major manufacturers, Abbott, Boston Scientific, and Medtronic, and you can see that really only about a 9% growth. So really not this, oh, it's going to go crazy that people want. So where do we sit now? Tigo Medical is doing the Performance 3 trial on one of the national PIs of it, that it's direct carotid access, so TCAR, which is not a so broad term, it's a generic term. They have their own sheath, and they use a NeuroGuard IEP that's shortened, and that's about 40 people from being done. SpireMD that has the C-Guardian stent is now doing a transcarotid trial using the Silk Road flow reversal, and they have their own Silk Road, so they have their own flow reversal that's coming next. And then probably the thing we're most waiting for, which is the CREST-2 trial. We're going to talk about that. That's optimal medical therapy versus carotid endarterectomy with optimal medical therapy, optimal medical therapy versus carotid stenting with optimal medical therapy. So it's not going to tell us is stenting better than surgery. It's going to say, is treatment at all with this modality better than optimal medical therapy or this modality in optimal medical therapy versus optimal medical therapy. When we talk about optimal medical therapy, here's one of the issues that we're all going to have when the trial comes out. Optimal medical therapy is LDL less than 70, blood pressure less than 130. However, they have an outside company helping doing this. And if patients were not at optimal medical management, they'd be back weekly to have their blood pressure lowered and have their lipid level lowered to get them to optimal medical therapy. I don't know about anybody else's practice. I have a ton of patients whose blood pressure is not well controlled, cholesterol is not well controlled despite prescribing statins, talking to their PCP, talking to their cardiologist. So if you look at the endpoint, which is going to be a patient of a stroke or death within 44 days of reambulation, or an ischemic stroke after 4 years, it may tell me is optimal medical therapy best, but is that an achievable optimal medical therapy in today's world? And this is what it is. And so, patients are really well controlled. And I don't think that's going to be achievable in my patients. So, I think it's going to be a big reach in the real world. It's just like that T-Rex, like I want to reach for that toilet paper, but I can't quite get it. I want that optimal medical therapy, but I don't know how many patients of mine I'm going to get. So this is where I love being a vascular surgeon because you really want to put it all together. This patient had a vein patch, they developed restenosis, they got a carotid stent, they developed again a restenosis, and then we did a redo carotidectomy with a restenosis removal stent. And so I think the one thing I'm proud of and I'll never give up is that I want to have all these tools in the toolbox. And for the people to say, I don't need to learn how to do carotid stenting. We all said that about EVAR. We all said that about iliac stents. Guess what? It's something you need in your toolbox. We said that about TCAR. And today, I see people that all they do is TCAR. I still do more endarterectomy than anything else because I don't think stents treat calcium really well. And until we have a way to treat calcium well, I want all these tools in the toolbox. So, what is best medical management? And we know there's some predictors for risk factors for people having events, and that's severe stenosis, the TCD detected microemboli, plaque necrosis and Doppler, sign infarcts on brain imaging, a CT or MRI, decreased cerebrovascular reserve, increased juxtaluval hypoechoic area. At the end of the day, when you're in the office seeing these patients, it's easy on an individual patient that might find that some of the risk factor, but it's hard to sit there and say, is your asymptomatic risk 1% per year? Is it 4% per year? And so it's really hard to say, but once patients have a stenosis, I think they're all sort of worried, and it's not a difficult thing to say to someone you need to be treated. I know this SVS guidelines for asymptomatic patients is 70%. I'm a product of Dr. Hercher. He's always said 80%, and so I don't treat asymptomatics till 80%. But that's why I think it really needs to be individualized. So looking in conclusion, carotid disease is actually the most studied vascular. I would challenge it's one of the most studied diseases of anything we do. Carotid endarterectomy has matured and evolved over time. We have excellent results. If you want to believe it or not, carotid stenting is matured over time. There was always a higher minor stroke risk. We now have devices that basically made that equivalent to what we've achieved with surgery. TCAR, though never randomized studied head-to-head, has generally had the equivalent results in endarterectomy. Best medical therapy is evolving, and we all need it. It's whether or not when CREST-2 comes out, are we going to be able to achieve that in our practice? And I don't think we will. And so, I think you can treat with both surgery, stenting, or TCAR. I do think you should treat patients who are symptomatic greater than 50%. I still wait 80% for my asymptomatic patients. I do think there's patients who maybe a transfemoral stent's better, maybe a TCAR is better, maybe endarterectomy is better. There's some patients, all three are good, some two of the three. I think that's where you need individualize it to the patient and their risk. And, whether we like it or not, just like everything else we did, we sat there and debated, should people have an EVAR? Now, 85% of the United States gets an EVAR, and technology continued to improve until it improved our outcomes. And now that we start seeing industry investment again, I'm going to tell you, our results are going to improve. We know that flow reversal is great, and the nerve intervention work, they use balloon guides all the time that I've never used. And so, I do think we'll see adaptations. You get better flow reversal from a percutase method. Someone's going to figure out how to do a TCAR from direct carotid access without having to do an incision. And so I think for us to grow, we have to. With that, I'll stop and take questions.
Well, information and data, history of carotid endarterectomy and carotid disease treatment. And I'm going to start with an open question, and you kind of answered it with that one patient at the end. In today's world, when do you use redo endarterectomy? Because I remember seeing that paper presented at SBS. I remember doing redo endarterectomies all throughout fellowship and not doing stenting until the second half of my fellowship. And so when do you do redo endarterectomy? Because I hate to say this, but it's a good operation.
So the first thing I do is get a CAT scan, and I want to figure out where the proximal disease goes to, where the distal disease go to. Is it something I can get to safely? Is it something where I can safely clamping? And for the densely calcified carotid that is, restenotic, or it's in a nice easy surgical area, I still do surgery. I know my younger partners all freak out about it, and it's really a nice operation. I sometimes can still redo an endarterectomy, but I have a pretty low threshold if it's difficult to just do an interposition bypass. And I sometimes use vein, I sometimes use BTFA. The data sort of suggests maybe those outcomes are equivalent. And I agree with Dr. Hircher, if you do enough, vein's always going to win out. But it's a nice short operation, and when that's the operation, or they've had a prior stent that's failed, then if it's in a surgical area I can control, then the nice part is you basically reset the clock, and 4% will have a re-restenosis, and then you can go back to conventional therapy again.
Anybody else have questions? Jerry.
Well, first of all, thank you for coming. You were one of our professors. This is really sort of a simple-minded, perhaps very focused question. Everything you've shown, why would someone pick the carotid artery stent site?
So if you can do it with an equivalent outcome, then if you do it remotely from either a radial approach, a brachial approach, a femoral approach, you get rid of cranial nerve injury at all. So the one advantage, you get rid of cranial nerve injury. And two, I think the difference is when you can get a CT scan, you're not doing diagnostic angiography and finding out, there's all this calcium, there's all this arch issues. Because when you're starting a procedure, you're generally in the mindset, I'm going to complete the procedure. When you get imaging ahead of time, you can show that. And so generally, I've always said to a patient, all right, you can have this incision, or a little puncture. The average patient, if you told them the outcomes were equivalent, will almost always pick the percutaneous option. And so I think it's our job to make sure that we can do it with an equivalent outcome, or it's not the choice.
So are you all doing a fair amount of stenting?
So I've always done some carotid stenting. It was much more from maybe 2001 to 2006 when the trial started drying up, but I've still done about 20 a year, and it's generally it's been for restenosis, and because of the Medicare guidelines, it was that. But I would say I'm doing a little bit more of it, and I think that's generally because now I have some devices that actually may achieve equivalent outcome. When you use the devices for just hearing from the C-Guardian trial and the Performance 3 trial, there was always a higher risk of stroke, and so I've used it cautiously. Now, the amazing thing is my stroke colleagues and my nerve surgery colleagues have all but given up surgery, and they do everything percutaneous. And so I think it's all in terms of what skill set you're comfortable with. I think it's no different than I talked to many sites where many young vascular surgeons are doing no surgery anymore. They're doing TCAR. And I sort of look at that one puzzle doesn't fit all, and having lots of tools in the toolbox. Just when I first learned interventional therapy, if one wire didn't work, one catheter didn't work, if you had 50 other to try, you can get it done, as long as you didn't spend forever doing it. And so I looked at both endarterectomy, TCAR, and transfemoral, as long as they have good outcomes, they can all be used.
was an absolute turn of course. Reminds me, it's really fortunate to have you here and really fortunate to have you in leadership at the SDS there, particularly in the policy space. So you talked a lot about the religions of things, tacking, not tacking, open, endo, how you neuromonitor, what specialties doing things. What's your advice to societies, to institutions, and to individuals in navigating these things that are always framed in terms of the best thing for the patient? But how do you tease out profit, territoriality, and cost to the payer as some of the other things driving this? How do you navigate that? I mean, you were smack in the middle of taking a step back as the specialties for least busy doing carotid stenting and advocating across societies for bringing it back into the toolbox for everybody.
I think, Dr. Hercher said it best, the results being everything. You look at the cardiac surgeons, they're mandated to have the STS for every hospital that's doing coronary bypass grafting has to capture their outcomes. The problem is that I'm sure just at UVA, at my institution, I belong to BQI and there's 13 modules. I have 5. I can't afford more. And so there's no push to help offset those costs of your registry person, of the people that capture the data, whether it's a doctor doing it and then adjudicate the data. And really, the nice part about the BQI, it's been sort of useful across all areas, but then I find out the BQI sort of relax on that. And there's institutions where they'll sit there and say, oh, you can just collect the vascular surgery. And so to me, if CMS really cared about quality, they would force us to actually capture outcomes, but provide some economic incentive to do that where it didn't become cost prohibitive. Because if you can capture outcome, then locally, local people can actually fix when there's issues. And so we use VQI, we get it for every single department. What happens is if we look to make sure our institution meets the standard for symptomatic and asymptomatic patients, and then we look by department, and we have everybody in the VQI, and right now it's 88 people every year I have to sign off, so that when there's an issue, and I know what physician it is, we give that back to the department they sit in to sit there and say, hey, your outcomes aren't where they need to be. You now need to pair with somebody else to get yourself back down to below the norm. And so, but that really gets rid of the local issues if you empower people to collect the data. And you have to collect it, not use it in punitive fashion. You have to collect it and use it quality improvement fashion. And the problem is that that's a slippery slope in many places where egos and money get in.
Anybody else? I saw another hand.
That was a fantastic talk. You showed some data that there was about a 10% growth in stenting. So if that trend continues, you'll have double the number of stenting in about a 7-year period, assuming that continues. Do you foresee that changing similar to what happened with the aortic repair, where stenting will be primary approach as opposed to carotid endarterectomy? A lot of private practices have shifted to stenting as their primary mode and their only mode.
I don't think you'll continue to see it continue to grow like that, but if you look at the data that's come out since then, I've met with the industry since then, what they're saying is that TCAR still continues to grow and stenting continues to grow, but they continue to grow both in a growth of overall procedures, which whether that's merit or not, I don't know, but it's continuing to grow at the expense of endarterectomy. And what I worry about is that going to be at the expense of, there's very few people who are doing complex open aortic surgery, complex lower extremity bypasses. I mean, I worry about the vascular trainees, what's going to happen in 10 or 15 years if enough of us to know how to do endarterectomies. And so I do think there's an inflection point where it's going to sort of plateau. I'm not sure where that is. For aortic surgery, it's 15% being done open now. And if I look at IFUs, per IFU, maybe 65, 70% of devices can be used on label, but we clearly know that still to this day, off-label use has inferior results. That hasn't stopped the vascular surgeons of the world still doing it 85% of people. So I think that's where if we look at our outcomes, we can honor that and maybe continue to innovate, improve, and actually drive the needle lower.
Another question. I have one final question. Nobody else does. You just briefly touched on it, but there's a whole stream of thought now that neurocognitive long-term outcomes. Patients after carotid intervention is a big deal to look at. In particular, clamp being the best embolic protection, and then there are MRI proven clinically silent hits with stenting, and to some degree TCAR, not quite as much as transfemoral stenting. A, do you believe in that? B, do you think that some of these newer stents, C guards, and some of the neuroprotection that is going to require filter replacement again, do you think that that's going to be an issue long term with those devices? Will they help?
I don't think it's been proven definitively, but the less amount of hits to my brain, the better I'm gonna feel. And Bezo's done a ton of that work, and it's really impressive. You know, the Brody embolic device that was purchased by Gore was a 9 French system that had a proximal common carotid balloon, an extra carotid balloon, and complete flow reversal. That actually had data showing it had equivalent TCD and MRI embolic rates to surgery. So I do think that it's coming. I do think with balloon guides, if you pick the right patients, you can get in and create complete flow reversal. We know with TCAR that not every patient has complete flow reversal because you still have flow in the external. Both TCD data and other data to show that you can sometimes flow coming down the external, going up the internal. You do TCAR, you see contracts come up, contracts come back. Sometimes you inject it, just kind of sits there. And so, you know, I do think we'll continue to iterate the devices so that you basically have best brain protection going forward. And I still think that complete reversal is the safest. And I was always amazed, even when we did the first Brody devices from transfemoral or did TCAR, some of the contralateral occlusion, that you can put up an occlusion and start flow reversal down the other side. And about 4% of people tolerate it. And you know, if it didn't tolerate, you can take the balloon down, wait 4 or 5 minutes, put it up again, and they tolerate. And you know, at the end of the day, that if you do these procedures well, it's only about 10% or 10 minutes of time you should be taking to do that. So you don't need flow reversal for long periods of time. And it's a surgery where you know you might have 30 minutes to an hour and a half of time clamp while you're working, and so that's where the obligate shunters come in and say, I don't have to worry about it because I have a shunt in, and I always was much rather be able to expeditious my time and not have to sew around a shunt.
Thank you very much. If nobody has any other questions or comments, we really appreciate it.